Hello, everybody. Good evening. How's everybody doing? That was not very excited. Okay, that's better. All right. I heard that we got some people out of practice tonight. Yeah? Sorry, you're not supposed to be excited about that. You wish you were practicing in the cold. Okay. Well, thank you everybody for coming. We really appreciate this is a great turnout for our talk tonight. My name is Chris Young. I'm the Director of Athletic Training and Outreach with Inova Sports Medicine. I see obviously a lot of familiar faces and some new faces, so thank you to everybody for coming and joining us for the talk tonight on current ACL prevention strategies and injury management with Dr. Bryant. So one of the things that I really enjoy is working with, obviously some of the soccer players and the different groups in our organization, but one of the really nice things is we get to be with folks like Dr. Bryant and others on our team that really challenge us in different ways and really work with us to try and make us better so we can be better for the athletes and the patients that come in the door. So let me just give a little bit of background of Dr. Bryant. He's board certified in both orthopedic surgery and sports medicine and currently serves as the team physician for the Washington Redskins and Washington Nationals. He joined the Inova Medical Group in 2016 with over 10 years of clinical experience after serving as an orthopedic surgeon, sports medicine specialist, and commander in the United States Navy. Dr. Bryant's naval career started after residency training at the University of California, Irvine Medical Center, and following residency, he completed a fellowship in sports medicine at the University of Pittsburgh to further specialize in the complex treatment of knee and shoulder injuries. While he was in Pittsburgh, he served as an assistant team physician for the Pittsburgh Steelers, University of Pittsburgh, Robert Morris University, and Duquesne University. When he was finished with his fellowship in sports medicine, he was stationed at the Naval Medical Center in Portsmouth, Virginia, where he also served as head orthopedic and sports medicine consultant to all naval special warfare groups in Virginia Beach. From 2011 to 2012, he was deployed in Kandahar, Afghanistan, where he served as department head of orthopedic surgery. I know I can speak for everyone at Inova Sports Medicine, and for Dr. Bryant, we're really happy about the turnout tonight, and without further ado, I will give you Dr. Bryant.
Thanks, Chris. So, yeah, thank you for all coming. I know you guys would rather be practicing, but, I grew up playing soccer myself, and it really is a big passion of mine. My daughter plays. I follow it regularly. I'm an EPL fanatic. So this for me is probably the best talk I could ever give. When I was asked to give a talk and come up with a topic, I said, well, I already know the topic because this is what I love. So this was easy. This affected me. And when I was in high school, I ended up tearing my ACL I think it was my last game of my junior year, and huge impact. And so, got it fixed, was able to get back and play and be involved. I've never had another surgery on that knee since. And I think the impact that made on my life, having gone through that, having the passion for soccer, really now I think drew me into sports medicine, but also makes me want to try to find ways to prevent other folks to have to go through that. And as a surgeon, trying to tell you how to not go do surgery is a little awkward. But in essence, I think that that's the best thing for you as an individual is to try to avoid, having this injury as much as we can possibly avoid it, so you don't have to endure the rehab and the surgery to go through that. So anyway, thank you for all coming. Thank you to Becky Menarchuk for setting this up, as well for Chris Young and all the other assistants on this. So without further ado, we'll kind of get involved. So what is the ACL? So the ACL is one of your main ligaments in the knee. There's 4 major ligaments. The ACL lives in the middle of your knee, along with its counterpart, the PCL. But it's the main one who's responsible for stability, preventing your tibia, which is the lower bone of your joint, from going front to back, predominantly going in the frontal direction. So it provides that frontal support, also provides a component of rotatory support. And it's actually made up of 2 discrete bundles. It's not just one piece of tissue. It's sort of 2 combined, separated bundles of tissue that make up that ACL tissue. Ligaments in general are just soft tissue pieces that connect 2 bones to each other across a joint. And then tendons, are the end of the muscles as they attach to bones. So muscles or tendons and ligaments are certainly different structures. So how common are ACL injuries? Why are we here tonight? Well, they're very common. This is a huge epidemic, and if you look across the room here, the most of you are female soccer players, and you're in that highest risk group. So thank you for coming for that reason, because we need to talk about this. This is a true epidemic. There's over, this is slightly old data, 250,000 ACL tears a year. This is certainly higher than that now as more and more kids are playing soccer. And, it accounts for about 65% of the knee injuries that occur in all cutting sports. Obviously, soccer is a big one. And then in combination with tearing the ACL, about 50% of folks that tear the ACL will also have a meniscal tear. I can attest to that too. I had both of mine, both medial and lateral torn within my ACL. So it's a big issue. In general, girls, females, are 4 to 10 times more likely to tear their ACLs than their male counterparts. This is an excellent book for any of you older kids, parents that want to pick it up. It kind of gives you a huge background in where we've come, where this epidemic lies, what kind of things can be done for it. But it's a really good insight into what this represents for our young population. The majority of these ACL injuries, they occur from a non-contact mechanism. Well, what does that mean? That means that there are ways that, we can't prevent contact from happening. If you run into somebody and that's how you get injured, well, that's never preventable, at some level. But if a lot of these are occurring from not running into anybody and not having that direct contact, well, why is it happening? And is there some way that we can actually get in there and prevent this from happening? And so what we've seen in general is that since 1974 with the Title IX, and you guys are too young to know what that is, but that was legislation that actually enhanced and facilitated women's sports in collegiate atmosphere, and it's a huge thing. It's very important, and it's very robust. But what this has also done in general is we've seen a rise in injuries. Well, that's because more people are involved in participating. So what is the overall prevalence? This was some data that came out of an injury surveillance system, which the NCAA uses across all of their groups. And this was old data from 1995, looking at a cohort from 1990 to 1994. And what we saw is that the women playing basketball and soccer were 16.1%. There was a 16.1% rate of tearing the ACLs compared to only a 2% rate in their male counterparts. So there was a big disparity in injury rates between men and women. And we're going to get into later that there's some updated data too that's interesting. But in general, so now that folks that have had, this is a more recent study that was presented at one of our sports meetings 2 years ago. In soccer players that have had an ACL tear and had the surgery for it compared to non-soccer playing athletes that have had an ACL performed, that the soccer players that then return to playing soccer after having an ACL reconstruction are actually almost 4 times more likely to have another tear. So why is this happening? Let's go back one. So why are women, girls, more at risk than boys? Well, there's certainly a lot of these things that we can't fix. These are what we would call non-modifiable risk factors, things we can't change. Certainly some of these have to do with anatomy. The central part of the knee we call the notch. Well, that has, in some respects, some different sizes compared to those in the males. There might be a little bit more narrowing there. That might impinge on that ligament and result in tears. Some women also have a little bit more relative looseness to their ligaments than do males. That's the ligamentous laxity. And there's also some alignment characteristics of the bones, which we call tibial slope. And this is seen to be over a bell curve, a little bit different in women than in men. And this might also have a little bit more potential stress related to the ACL graft. These are things we can't change. This is how we're born. Developmentally, the boys undergo an earlier and more robust neuromuscular spurt, and this is seen as being somewhat protective. And then unfortunately, that's just not something that happens naturally in the women. Now also, ACL has been shown to have some estrogen receptors, and so there might be some monthly cyclical changes and at-risk periods where the ACL could be torn. Again, non-modifiable, we can't change. It's nice to note and look at, but it's not going to help us in the end to get where we need to go. So what about modifiable risk factors? What can we change? So, and this is the ultimate basis of all these ACL prevention programs. This is what we want to focus on. And again, going back to earlier, 70% of all these injuries are non-contact anyway, so we should be able to maybe prevent something. And what are the big things that we need to focus on? What are the issues? Well, neuromuscular deficits seem to be the key. And this is what, and we've kind of broken this up. There's ligament dominance, there's quadriceps dominance, leg dominance, and trunk dominance. So if we talk about ligament dominance, this is in essence where the muscle around the knee, the supporting muscles, the quadriceps, the hamstrings, that they don't adequately contract, they contract differently, maybe one's outweighing the other, and then ultimately this will impart more force across the bone, the cartilage, and those ligaments that connect the two. And what we can see that in these pre and post pictures here is that on a tuck jump exercise, the girl on the left, this is actually the same girl pre and post, pre-training, her knees kind of come together, and we call this valgus, where they kind of get knee knock position. That's a valgus position of the knee. This knee position in this landing maneuver actually results in higher forces across the knee and higher forces across that ligament. When we adjust and train the individual to jump and land more correctly, we can actually modify, we can change. That same individual is now landing in a more crouched position. The knees are not knocking together, she's not in that valgus collapse, and this is gonna ultimately be more protective. Quadriceps dominance. So women in general, and again, this is one of the, we're not sure why this happens, but this is probably be more related to that neuromuscular spurt that the men have that the women don't typically get, but they ultimately get a little bit more robust quad versus hamstring. Well, why does that matter? Well, that's important because the quadriceps is actually what we would call an antagonist for the ACL. So the quadriceps, which becomes your kneecap and your patellar tendon in the front of your knee, pulls your knee, the tibia bone, which is that lower bone, more forward, and that would actually pull against your ACL. So every time you're jumping and landing, if your quadriceps is more active and your hamstrings aren't helping your ACL out, that can ultimately impart more strain across the ACL. So as we see here, we have the good and the bad. So that valgus knee collapse on the right with less crouched landing position is seen to impart more stress across the ACL. When we retrain that same individual to activate muscles more appropriately, equally, et cetera, then we can see the good mechanics can be taught. Then we have leg dominance. And women in general tend to show a side-to-side asymmetry. Asymmetry means the two sides aren't the same. So coordination, flexibility in the muscles, all women, or most women tend to have a dominant side. And well, that's great for that leg, but the non-dominant side is potentially more at risk because it's not, the landing is going to be awkward and off and so on through all the maneuvers. So we have to retrain and make both sides more symmetric. So trunk dominance, this is another thing where during landing and deceleration means slowing the body down as you're going through a move and pivoting and twisting, that the trunk, the center of gravity, tends to be more excessively away from the center. And what this will then do impart more stress and force across the knee and the legs in general, which can then lead to higher ground reaction forces and moments across the knee, which all this translates to is increased force and stress. So again, these different inadequate positions, excessive positions during different motions and maneuvers, this ultimately can produce more stress across the knee. These are all things that we can change. So can we completely predict an ACL injury? No. No, at some level, I mean, even with all this adequate training or no training, at some level injuries are going to occur. But what we can do is predict those at risk. So we can't predict, if you are definitely going to have an ACL tear or not, but we can predict like how at risk are you to having an ACL. And Meyer, this is a great, often quoted article in 2008 from Athletic Therapy Today that goes through a lot of this. They talk about all the ligament dominance, everything we just went over about how to identify at-risk positions. So again, what are the ones that we key in on? Well, single leg squats, single leg hop and hold, and then vertical drop, which is also like a tuck jump. These are the keys that we can kind of identify the valgus collapse, the quadriceps dominance, trunk dominance, and these maneuvers that we can then modify. So these are how we would necessarily put you through a regimen, identify are you at risk, are you not at risk, and then take you through the program to focus on the proper strengthening and neuromuscular training. So again, this is just kind of in summary showing the good and the bad positions, and you can see how the most of those bad positions, if not all of them, will result in that knee kind of buckling inward, again in that valgus position. So the overall position of vulnerability for ACL tears is what's seen as this dynamic valgus, which again is that knee buckling inward. The ankle will also change, as well as the hip. So the hip ends up coming in as well. And so what we need to do is modify all those during all maneuvers, jumping, landing, pivoting. So what does all this mean? You know, if we can improve or modify these at-risk and vulnerable positions in these landing mechanics, does this make a difference? Does this mean we can actually prevent some injuries? Well, it means that we can. And, you know, in general, especially for one sport athletes, I think it's very important that some aspect of time off that particular sport. So if soccer's your thing, I think cross-training, whether it be basketball, swimming, track, you know, any other sport, volleyball, you know, having the body learn other mechanics through other means and doing different maneuvers actually does a lot of things. It decreases overuse injuries, which is a whole nother talk, but it also improves overall performance and in all the sports that the athlete might play in. A general strengthening and stretching program, I think, incorporated into the daily routine, weekly routine of both team sports and individual aspects is very important. But you know, the big thing here is keying in on the neuromuscular training, which is going to help correct a lot of those things that we just identified as being problematic. So in a more recent publication in 2014, they basically took 30 female soccer players, they put them through a rigorous 12-week neuromuscular program, and they did both pre and post testing gamut of different position jumping mechanics, and then both videoed them and took other laboratory measurements, and were able to show that every single one of those poor risk factors that is modifiable was able to be modified. So what this essentially did was actually a pretty well-designed study, and it just proved that we can take from A and get to B effectively, and even over a relatively short course of time. Also, in an overview and a systematic review, a meta-analysis of several publications that looked at, and all these different individual articles that were reviewed all had results of their own individual ACL prevention programs and how effective they were at preventing, you know, ACL tears compared to a previous year's cohort. And in general, there was an effective consensus of 20-80% reduction in ACL tears in these studies where they put their athletes through a sustained program. And this ended up in an overall cumulative, if we extrapolated the data into all of them, of a 52% reduction in females and 85% reduction in males of ACL tears. Now, what we also know from a lot of this is that some studies that have looked at sustainability have shown that, you know, if you go through the program once and then you forget about it and you never do those exercises again, you are likely to revert back to those bad, poor positions of mechanics, which then, as we know, we just discussed, might put you back more at having a higher risk. So it's also about sustaining and maintaining what you've learned and incorporate it into everything going forward to help sustain that preventative aspect. So an update on that NCAA college database that we talked about before, this is more of a recent publication in 2016. They now took another 5-year cohort, 10, 15 years later, and compared it to that one we talked about earlier. And what they saw is that we're now seeing about a 29% decrease in ACL tears for both men and women. And that's fabulous because, you know, we're starting to incorporate a lot. Different universities across the country are incorporating a lot of these sort of attributes that we've now identified as being helping to prevent injuries, and it seems to be working. Now, this study alluded to this as being one of the potential factors with these results, but it's not a study that could prove that that's a cause and effect relationship, but it is interesting to note. There's also been a change in playing surfaces at a lot of these schools across the country where there's a lot more turf and artificial surfaces that have also been seen to help prevent some of these injuries. So there's probably multifactorial. So what are you know, as far as ACL prevention training programs go, there's several different types of these out there. What we found and what we feel is that universal neuromuscular training is probably the most cost effective. It's also the most accessible type of training to undergo, as opposed to very expensive video screening training where, you know, they take video of you doing things and try to have you watch yourself and then modify from there. That's more time consuming, very expensive, and hasn't been shown to be as effective overall. So ACL Prevention Training Programs, well, what's the ideal program? What do they do? Well, they're going to incorporate a lot of different things: stretching, strengthening, plyometrics, that has a lot of jumping mechanics, agility, speed, education, verbal feedback. And then as far as timing goes, when is this done? So ideally, you sort of get a jump start, a whole a boot camp, if you will, of this to kind of get a jump start into the program, and then it's sustained throughout the entire season, and ultimately, hopefully, sustained throughout year to year with all the individual groups. So what are the potential issues here? Is compliance an issue? Are people doing this, an issue? Well, yeah, it is. Some people have thought that this is too expensive and so therefore not useful. It's time consuming. It deters from practice. Yeah, some of these may be true, but there's also some things here that need to be stated. I mean, yeah, is it expensive? Well, yeah, it might be, but at the end of the day, so is an ACL tear as far as the expense monetarily, plus also the expense physiologically. So compliance really shouldn't be an issue. What we're trying to prevent is having to undergo all this stuff. If it's expensive, it's more expensive individually if undertaken on a separate level than it is as a team. And when it's done as a team, it can actually be very, very affordable. Time consuming, well, it shouldn't deter from practice. If you incorporate it in the warm-up, it becomes part of the normal day-to-day routine. And in fact, what we've seen with several programs that have done this too in some of those studies is that the overall performance of the athletes seems to improve too, because speed increases, power increases. There's things that are focused on during these neuromuscular training programs that aren't just about preventing ACL. It's not just about that. It's about making a more effective athlete, if you will. So a recent example here that we just did this last fall was we took EXOS, which is a recent collaborator, and we went to the Great Falls Soccer Organization here locally, and we did an ACL prevention program with some of their teams, the 06 and 07s. We had 67 girls. We did a 10-week program, 1 session per week. My daughter was part of it. And, this was a 60-minute per week episode, and they involved pillar prep, movements, movement preps. They used medicine balls for power and did different exercises, did plyometric skills, movement skills, incorporated a lot of power movement, and then also we incorporated nutrition into that too, which we think is a huge component of just being healthy and being a good athlete. And then we have some data from that. We, not just what, people liked it and they, we had a 91% satisfaction rate from all the girls, but what we saw in the far right category is that everything increased. We had a 7% increase in push-ups, a 53% improvement in squat strength and squat numbers. We had the improvement on both the counter movements, and then the speed, which is the lower one, was also improved. We had a 4% decrease in speed seconds, so again, increase in speed. Moving to the left, which is more the non-dominant side for most of the girls, versus a 9% to their strong side. So this is, this was big, and this was just, 1 hour a week for 10 weeks. There was some compliance, so, I think most of the girls probably went to 80% of them. But essentially was shown to be effective at increasing a lot of this stuff. Now, we want to follow this cohort, which we have access to over the next several years to see, okay, well, how does this maintain the ACL prevention aspect of it? We didn't have any this year, and we don't hope to have any, but, it's something that we're going to continue to follow now that we have an isolated cohort. So, but in the end, what happens if it does occur? So if you tear your ACL, what happens? Because at the end of the day, we're not going to be able to prevent everything. Ideally, we want to promptly evaluate, intervene. Oftentimes we'll certainly get x-rays right away to make sure there's no fracture, and then we most frequently get an MRI to help diagnose not only the ACL, but look for any other injuries that can occur as well. If you do tear your ACL, non-surgical approach is generally not very effective, especially in someone who's young and active. Most folks that have ACL tears will develop meniscal tears, about 90%. Most of those, about half of them are acutely with their ACL tear, but the others will develop meniscal tears over time. These cartilage injuries, which the picture shows, these can happen if it's not treated effectively. So there's a lot of reasons that we should address the ACL with surgical means if and when it happens, especially in someone who's young and active. So it's definitely a good option. It results in about a 70 to 95% success rate for a stable knee, and this is just across numerous studies put together. But we still have an issue with getting back to that prior level of play. And only about 60 to 65% of people that actually have an ACL reconstruction done will actually ever get back to that same peak level that they were at before the surgery and before the injury. The pictures on the right just show a normal ACL on the top and then a torn stump of the tissue on the bottom that's seen arthroscopically. But so generally these days, as opposed to when I had mine back in the early 90s, we do it primarily arthroscopically. So the nice thing about this is it's more minimally invasive. Patients go home same day. We remove the torn tissue because that by and large isn't useful anymore. It's not going to be effective at becoming a good ACL again. And then we want to drill new sockets and tunnels and prepare the atmosphere in there in that knee for the new ACL graft to be placed. And essentially, in how I was trained at Pittsburgh, which I trained under not only Dr. Robin West, who I've now joined here as my partner, but under Dr. Freddie Fu, who in the ACL literature is probably the international guru on this. Ibrahimovic even just went to him not too long ago for his ACL reconstruction. And he was my main ACL mentor. And it was beat into us as fellows from day one that, you know, we don't do non-anatomic ACLs. We put that ACL back where it was. And I think that's a big take home, you know, if and when this does happen, you know, to anybody, that, you know, you want to seek out someone who you know, does this and puts it back really where it belongs to avoid future issues. So how do we go about doing it? What do we use to make your new ACL? Well, we can use your own tissue. We call that autologous, and that's certainly for young active individuals under the age of 35. That's by and large the best choice. And most specifically, especially for soccer players, we tend to lean towards using the patellar tendon one, and especially not any of our contact athletes. Hamstrings are also a very good option. I think that between the two, I think they're pretty equal as far as effective outcomes. There's also a quadriceps tendon that we can use, a little snip of that to make a new ACL graft out of. I think that's very useful for any revision or redo cases. There's also the option of using allograft or donor tissue, but again, you know, in this age group, I would really caution against the use of that. The overall re-tear rates of allograft tissue, if used in a young athlete, can be upwards of 30%. So it's pretty high, and I wouldn't do it if it was my child. So what do we look at? So this, you know, this tissue we're using to make a new ACL, how strong is it? Well, actually, anything we use is stronger than the original. So I mean, from a strength aspect, it's far and away stronger than what was already there. The strongest graft that we can really use and put in there tends to be the hamstring. We kind of loop it over on itself several times, but by and large, it's really not important about which type of graft we use in that setting. So, you know, just a few snippets of a recent case that I had done. You know, we've got the graft preparation on the back table. That's the far right top is a picture of what the patellar tendon graft ends up looking like with a little piece of bone on each side. And we put those tunnels back in the spot where that original ACL was, and then ultimately place it in, and, you know, we want it to look like that, which is what it looked like before. So we got the ACL crossing from bottom to top in the near portion of the picture, and then you have your PCL, your posterior cruciate ligament, behind that. So we're restoring that anatomy. Now, graft healing, and this is another big topic. I mean, the biggest question that I ever get as a surgeon once we start taking an athlete through this process is, well, when can I go back and play? And my answer is usually not too soon. And historically, I think a lot of surgeons over the last several decades have been allowing athletes to go back at 5 months, 6 months, and sort of taking pride in, well, I got my athlete back to playing at 4 months or 5 months. And you know, and in the end, that we've now found through several studies, and so that's not the best thing. And there's very good documented reasons for this. If you look at this picture alone, this is, again, from Pittsburgh with Dr. Fu. We were doing this study when I was there, but looking at the graft when we put it in initially is that top left. It's nice and dark and black, and that's what essentially a normal ligament would have appearance of on an MRI. Well, at 6 months, it doesn't look like that anymore, and that's not a torn ligament. That thing's still intact. There's been no trauma to this individual, but it has this kind of grayed out appearance to it, and that's because it's sort of undergoing a natural change. We call it religamentization, and that process takes a long time. And then at 2 years, that graft now looks like it's back to normal. So it does take a long time, and I think that's the hit-home message is that you can't expect to return too soon and before that graft has adequately healed and undergone the necessary changes and reorganization that it needs to. This graph, I think, also really shows that. It does a few things. One, if you look at the top, the dates, our PT stands for patellar tendon. That's the patellar tendon autograft and the hamstring autograft. Those are the top two. They will, if we use your own tissue, it's going to heal to you faster, without a doubt. Allograft, the donor tissue, takes several months longer to heal adequately to you than it is if we use your own. That's another reason why we probably see higher failure rates in a young active population. But if you look at the graft and that, the curve that kind of dips down from surgery, is it takes a long time for that curve to ever get back to that 50% mark, somewhere upwards of 7 to 8 months. So I think nowadays when I counsel my athletes about when they can go back, it's a minimum of 9, trying to stretch them to 12, and if they really can wing it, 18. Really build up the leg, go through the neuromuscular training programs, build everything else up, let this graft heal, and then return and have a much safer re-rupture risk. So, when we talked about the donor tissue briefly, why is it higher in these young athletes? Well, there's probably a couple reasons. A, it takes longer to heal. We know that a lot of these allograft preparation, these companies, they irradiate their graft, they use x-rays. Well, that's inherently bad for tissues, and they probably have higher failure rates from that. But ultimately, a lot of these individuals were probably sent back also too soon in a lot of these studies, and so they were incompletely rehabilitated, resulting in higher failure rates. The top numbers overall, 7 to 29% re-tear rates in use of cadaver donor tissue in young athletes, as opposed to 3.5%, and that was the 3.5% was garnered off a study that I was a part of down at the Naval Medical Center. So in general, what are we expecting for the rehab? In general, with a physical therapy, it's usually about 6 months. Then we tend to put them into a bridge type program and ultimately into more of a neuromuscular program. But there's a lot of missed playing time. Athletes get upset about it. There's potentially the financial burden, disrupts the family, having to take kids to physical therapy and do this and that. And ultimately, it's going to be a long process. And in the end, there's been several studies that have elucidated that, the return to rate's not 100%. And even in the NFL, we're talking about elite athletes. This was shown at one of our meetings in 2006, that over a 5-year period, there's only a 79% return to play. And there's about a third of those folks had a reduction in their overall performance. The people that did the best after having their ACL in the NFL setting tend to be the ones that were like more of the first round draft picks, the elite of the elite, because they were less likely to have a significant reduction in their overall performance. And it's probably because they're the best athletes out there. So overall return to play, again, the big thing is the 65% mark. Now, I think we do get better than that, but this is what the data shows. This was 2014. It's not that long ago. Factors that are associated with a better return to sport tend to be male gender, and it's probably going back into the jumping, landing, and modifiable aspects of this. The younger age, because the younger you are, the more likely you're to heal and get back from anything. These elite athletes, and having a positive psychological response. And we actually, Dr. West is putting through a grant right now to look at more specifically this psychological aspect. There's a big thought process nowadays that the psychological aspects of what goes on when kids and young adults and even adults go through this process and tearing their ACL and trying to get back, especially ones that are athletic and truly playing sports, is that there's a huge psychological burden, and how the individual responds to that oftentimes determines whether or not they get back to play or not. So we're going to start looking into incorporating more of a psychological, like a sports psychology aspect into the rehabilitation. So in summary, without a doubt, prevention is the best medicine. I like to see you guys playing on the field. I don't want to have to see you in the office. That means something bad happened. We've had several large successful clinical studies looking at this in the United States. We need to do more and be better about getting it out to people to use in the teams and in the athletic atmospheres. In general, it's more important that you pick a well-designed program than not picking one at all. And even though we're talking mostly about females, but that's primarily because they're at the highest at-risk group. Female soccer players, biggest at-risk group, but they benefit everybody. The men and boys that have gone through these programs have also seen a significant decrease in their overall ACL rate. So it's not just female specific. These are important all across the board. But I wanted to, basically thank you for coming. I do want to invite Jeff Huggins. He's a certified athletic trainer, strength coach. He's been with EXOS for almost 5 years. He's actually recently come to us, or in our setting up here, to our EXOS. But he's been involved at the EXOS at all different levels, whether it be tactical, corporate, teams. So he's dealt with a lot of elite athletes, professional athletes. So we're glad to have him. I'll have him come up. I'd like to just open it up for general questions and answers, about anything, whether it be ACL surgery, a lot of the neuromuscular programs, what EXOS offers. Again, and he's one of the coaches that kind of worked through the program we did with the Great Falls team. So, any, sir?
I'm an athletic trainer, a high school athletic trainer, and one thing that we've noticed over the course of my career is that the more contact hours that the kids have, the higher percentage of, I'm sorry, it's for everyone, I'm sorry. Is it on?
Go ahead.
My question would be is, has there been any studies on like how many practice hours per week related to ACL injuries?
Because it seems like, especially at the middle school and high school level, you get a lot of kids who are playing on either multiple sports at the same time or multiple teams of the same sport, just two soccer teams at the same time. So do you have any information on background about that?
To my knowledge, it's a very interesting. So the question is relates to actually like, does increased time practicing during a week or competition play put you more at risk? I think that's kind of the basis of your answer or your question. It's very similar to in baseball. We've found that increased pitch counts can lead to more in pitchers can lead, especially in little leaguers and the young athlete. Increased shoulder and elbow problems and injuries, so more of an overuse. And to my knowledge, I'm not aware of anything specific for the ACL for that, but it does bring up an interesting topic in the sense that, is this a fatigue problem? And I think in essence, that's kind of the meat of, the heart of where you would be getting at with that is overall fatigue, is that a risk factor? Hasn't been identified as such, but I don't think it's been directly looked at. Certainly I don't, especially when you're young, you can endure, like I can't do two-a-days and 3 different sports a week anymore. But, the young athlete can really endure a lot more of that endurance and bounce back from neuromuscular fatigue. But it's an interesting question. But I'm not aware of any specific data.
Because we'll have kids that leave the high school practice
Mm-hmm.
and then go practice another 2 hours for, an ODP team or something like
Yeah.
that. It seems there's got to be something.
Yeah, and I think more important there is, not sure if it necessarily relates to an ACL risk, but I can tell you most likely it's going to relate at some level at some point to an overuse injury risk. And that's where, that going back to that one slide of the one sport athlete that doesn't cross-train, doesn't take the time off. I mean, I usually counsel patients, like I say, if soccer's your sport, well, 3 months out of the year, you play no soccer. I don't care, there's no soccer. And that's been shown to be more effective at preventing overuse injuries with any sport, whether it be swimming, baseball, soccer, volleyball, you name it. At least taking about a 3-month block off and doing something else or nothing at all, picking up a guitar or a violin or, changing is seen to be the best at preventing an overuse injury. Now, we don't really view the ACL tear as an overuse injury. It tends to happen like with an acute event. It's not like an attritional problem, but it certainly does raise the risk of overuse stuff.
Excellent.
For a partial tear, do all of the recommendations apply for a partial tear just the same as if it was a complete tear for the ACL?
Recommendations for surgery?
Yeah.
Yeah, so partial tears, I think initially at the beginning of the talk, we mentioned how the ACL is made up of 2 bundles. I think the majority of what are deemed to be partial tears are truly probably more of a 1 bundle tear, and we used to see this in about 5 to 7% of all of the cases that came through us during my fellowship year at Pittsburgh, is, the majority of which are complete tears or 2 bundle tears. But every now and again, you can see the one that maybe had no rotational instability, so what we would call their PL bundle was okay, but they had a little bit of front to back instability. Their AM bundle was torn. And you can have the opposite too. So for those, and I'm actually taking care of one right now, we in general, especially if they're young and active, we recommend that they have that single bundle reconstructed, and there's more specific techniques to do that. It gets a little tricky, but we do it. And then we say that because at some point, think of it, if you've now, taken your ACL and you've taken away half of its ability to do its job, at some level, if you're going to continue to do the same kinds of things, the other one's probably going to go at some point. So we're trying to prevent that from happening by reconstructing it and getting it through. And that reconstruction process and the return and rehab would be essentially equivalent as if it was a full. But the surgery itself, we tend to leave the good tissue and just reconstruct the torn portion. So.
You mentioned the replacement ACL would be stronger than the original. Does that take away any flexibility or freedom in motion, or?
Yeah. So the question is, do we lose motion or something by somebody be putting something that's thought to be too rigid and too strong? Certainly, and that goes back to kind of my point I'm trying to make about doing it, putting that ACL graft back in the position it's supposed to be in. So doing what we would call an anatomic ACL. So certainly a non-anatomic ACL or a graft that's just kind of put, whether it's a little bit more vertical and not quite down where it's supposed to be, or the tunnel's just a little bit off front to back, this can have significant effects on motion. And I've seen that when I was in the Navy. At the Naval Hospital, we were a big referral center for the whole East Coast for anything related to knees and shoulders. And we used to see a fair amount of ACLs that have been done elsewhere that either retore or had been put in a little bit too far, maybe not in the right position. And there were several folks that we saw with limited motion either couldn't get all the way straight or lost flexion because of how that graft was put in. So it's not as much that it's stronger that causes that. It's really a matter of where it's placed. It's I think the big point. Yeah.
So on an ACL repair, are there any reasons or causes why the ACL repair would not be successful? You said sometimes it's too tight. What if the knee is too loose?
Yeah, there can be a whole host of reasons why it may not be successful. So if we take all else aside and say there's no meniscal or cartilage injuries and such, it also might go into that. And you have a truly just normal knee otherwise. Yeah, I mean, the graft position is probably first and foremost. Adequate tightening and maintenance of that tension during the healing process is very important. So if the fixation devices that we used in there that hold the graft in the right amount of tension during the healing phase, which is usually seen as the first 12 weeks or so, if that gets loose a little bit during that initial recovery, that can result in a loose graft, and that would potentially fail. But those are probably the biggest reasons why something may not just come out right. And a lot of that goes back on us. That's some of that's technical error. Some of it's, you can never prevent the post-op patient from slipping, getting in and out of a taxi on a wet surface. I mean, that can happen too, but the majority of those things are preventable on our end by doing a good technical surgery.
So if you have a loose graft, do you recommend, should it be redone? If you're an athlete, you're playing college soccer.
If you're having, I mean, if it's like you're through the healing process and you've got an athlete that truly has a lax graft and it's unstable, even though it doesn't look torn, I've taken those down and redone them.
What do you use the if initially you use the patella tendon, then if you do it again, do you use the hamstring or some?
Possibly the hamstring. My big go-to, especially in the young athlete where I still want to use their own tissue, is you've got a couple options. You can, if you're going to take something from the same side, the same knee, I would usually go for the quadriceps. It's a really good graft, and that's sort of I keep it in reserve for the revision setting. You can also take the other sides, anything, patellar tendon, quad, hamstring. The hamstrings in general, sometimes in a revision setting where we also have other worries to consider, like, the bone little tunnel that we make to put them in initially sometimes can widen. Well, the hamstrings, you're sort of limited on how big and fat you could make them. So the quadriceps, you have a little more leeway. That's why I think it's a better graft for the revision. So these are all sort of the technical things. But yeah, it's I still try to use something from the patient's body, ideally that knee that's already been sort of used.
Thank you.
I have a question for Jeff. Can you talk a little bit about the Great Falls program and what age you started with? Did you see a difference in the results, younger versus older? Was it pretty standard across the board? What did you kind of see from what you guys did there?
The results were pretty standard across the board. In terms of what we did there, was we implement, so our first thing we go into a program in general, whether that's strength or looking at movement skills, is just trying to build balance. So what we find is a lot of times is that there's a big disconnect between specificity and simulation, right? So if we know that we need certain movement patterns to be optimal for a particular sport, what do we do when we train? We generally try to reproduce those movements. So from our point of view, what we try to do is to come in and start building balance across what are the things that you do on the field, and then what are the things that you maybe do occasionally on the field, but we don't tend to quite as often, right? So we work through shuffling skills, we work on linear speed, absolute speed, and also change of direction, and we break those up pretty evenly, right? So that we kind of balance all those skills out throughout the entire time that we work with that team. That answer your question?
Yeah. Was the hour long enough for what you guys needed?
The hour it's optimal. It's what you do with an hour, right, more or less. So ultimately we start, the way we start is we work on one thing at a time, right? Ultimately, if I can't get into a good base position, then I'm not gonna fix, high-level multi-directional work, whatsoever. So maybe that first week is just working on a base position. We also have a concept that we call carryover. So that's saying if I understand an optimal shin position for acceleration, well, then I've just taught it across 4 different movement skills, right? So maybe we should hone in on those things that have the biggest carryover across movement skills. So obviously you always want more time with your athletes, but that's where, guys like me and then guys like the coaches in the room probably, have to have a negotiation constantly, right? But yeah, definitely enough time.
Yeah. And a little, I think a blurb about that too is I think, incorporating these programs, say into the teams, it's actually going to be really beneficial to have the coaches participate in that program as well. And the main reason for that is that coach is going to be more likely to then incorporate all those skills and all those things that were learned in, after that program is finished into the daily routine during practices. Again, incorporate into the warm-up. They've gone through it themselves. They know what it is. They know how to assess their own players for, hey, are you doing that quite right or wrong? That's going to, I think, when we talk about the maintenance and the overall prevention with time, that's probably going to be the most useful to help facilitate that.
I had attended a conference a couple of years ago with a physician that worked with women's USA Soccer, DC United. He's local here. He was working in regards to putting together a regimented strengthening movement pattern prior to practices for women. And it was just a set of exercises, took about 15 minutes before each practice or competition. I didn't know if you were aware of that or if there was any evidence-based research regarding that. If you'd heard of it.
Well, did they have a name of it? Was that one?
I know it was Dr. Vitek was overseeing that. I don't know if it took off or not.
Was it the FIFA 11 or? Because there was a stop sports injuries or something like that.
It was a couple of years ago.
There's
Again, I don't know if it
several
took
out
off.
there, and that was one of the things in that more recent college study that failed to kind of bring up. But that was also after the incorporation of a lot of the FIFA 11, which has to do a lot of these preventative maneuvers and stuff into a lot more of what the NCAA teams were doing across the board, and that was another reason why they may have seen an overall reduction in the ACL and knee injuries with that study.
Is that what the EXOS program is doing right now?
It's all very similar. I think one thing EXOS I know does that other programs don't is they also incorporate a lot of the nutritional mindset and kind of this whole body approach to a lot of things, and that's I think again when we talk about what's good for our athletes in general holistically, nutrition is a huge component of athletic prowess and being able to just go out there and be a good athlete. So Yeah, I don't know which one that is. My hunch is it's probably the STOP program, which was put out by the AOSSM, which is the American Orthopedics Sports Medicine Program.
Thank you. I had one more question too. In regards to the allograft, could you comment on fresh frozen versus how much radiation that those grafts
so
are
with
getting
allograft,
afterwards?
everything for ACL surgeries, allograft that's used is all frozen. It comes to us, it's basically held in a freezer and we thaw it out when we need it in the OR. So it's never fresh per se. There's several different allograft companies out there, and what we found now almost ubiquitously in the literature, really over the last several years, and when we start to weed out why allografts fail higher, and we now look at which company they came from, knowing how the companies all sterilize terminally their products. We found that radiation is the worst. Something called BioCleanse is the second worst, and then other ways of sterilizing that product tend to kind of now fall down where they're more on par with as if you used your own. So it's not just allograft itself that is the issue, it's how the allograft is processed that's becoming more and more the issue. So I know which companies use X, Y, and Z. I don't use those companies. Yep. And actually, I changed the policy at the Naval Medical Center Portsmouth when I was there, and got rid of, a certain company because they were ones that irradiated, and we switched to one that was seen in that particular study that comes to mind as the least likely to have a higher failure rate, or basically more on par with autologous or your own tissue use. And so we did that, and so if I ever use allograft anywhere, I basically request what I seem to think are the ones that are the least likely to be a problem. So, and it may not be the easiest to get, and I just tell them like, well, that's what we got to do. If it's your mom on the table, or your daughter, this is what you want me to do for her. So.
I have a question. This is for the fact that we have a lot of youth athletes in here right now. Jeff, can you give a couple pointers? I mean, the parents, we're not on the field. I'm a parent of an athlete, not this sport, but we can tell our kids till we're blue in the face. Follow what the coach says. Follow what the performance coach says. They're the ones on the field. They're the ones executing. Can you give them maybe 2 takeaways? They're all here today. I'm very appreciative that they all came, but I want them to walk out of here with 2 things. They've learned the severity of the actual ACL tear. It's going to happen. It could happen to you guys, right? I'm not saying it's going to happen. That would be terrible. But, here's your preventative. Jeff, can you give 2 takeaways that the girls can take back to practice?
Sure. Yep. I'll piggyback off the first thing you said. I guess the first one is listen to your coaches, right? Generally, there's a lot of experience there. It's easy to be excited to get on the field and to start moving around really quickly, but generally speaking, there's something to be learned every day at practice that's probably going to go into all the things that we're talking about here today, right? That's 1. 2 is listen to your body, right? So if we're not feeling 110% in a given training session or a given game, it might not be the day to go 110%, right? So listen to your body. And the last one is take your warm-up serious, right? As a coach, that's the number one thing that we always struggle with, is that we just want to kind of move our feet around just a little bit and then get out there and play soccer. Like, we get it. That's why you're here. That's why you're on the field. You want to go out there and have a good game, put out a good performance. But without a good warm-up, then we're talking about kind of all the risk factors that Dr. Bryant was talking about up here, right? So I think those are the biggest takeaways. Another one is, if you love playing soccer, right, then these kind of things are the education points that are going to get you ahead for a couple of reasons. We always like to make sure that as a company and as a coach, we have 2 main goals for all of our athletes. One is career productivity, meaning when you're on the field, how well are you performing on the field, right? That's what we generally care about. And then we come to kind of a seminar like this and we hear Dr. Bryant talk and you think injury prevention, that doesn't sound really, really cool. But the secret is that everything I do with all my athletes to make them run faster are the exact same things that I'm going to do to try to reduce your risk of injury, right? They're exactly the same. So if we talk about loading the hip more when I get into a squat position, or when we're talking about acceleration mechanics, utilizing not just my knee, but letting my knee and my hip talk to each other a little bit better, that's going to make you safer, but that's also going to make you run faster, right? That's going to make you change directions better, and ultimately be better on the field. So when you hear these things, try not to think of them in the context of, oh, that could never happen to me. Just say that injury prevention and a higher level of performance are one and the same.
That's a good point. I'm just out of curiosity, anybody other than myself in the room that's ever had an ACL tear? How many of us? It's all the old guys, all of those old guys. I'm glad none of the young athletes have had any. Let's keep it that way. Well, again, only for 2 weeks. Right after, only for the 2 weeks after surgery.
To play, they don't need to wear a brace?
No, I mean, if they want one, we'll give them one. But ultimately, the ACL functional braces, if you will, customized or not, have never been proven in any body of literature to prevent an ACL tear or a rotatory instability event from happening. I can also attest to that. I tore my ACL the end of my junior year. I decided, I played 3 sports. I was soccer, water polo, and swimming. I grew up in San Diego. Those were big sports there. So I went from soccer into swimming and then water polo, and I decided, well, my knees feels great, because after the first couple of weeks, all of that stuff settles down. You feel good. So I said, I don't need to have surgery. And soccer, played club a little bit, and it was doing okay. Got back into the fall to play soccer again with the high school team. Brace on, had a brace, customized, it was great. I thought, hey, this is it, I can do this. First full contact scrimmage, it went out of me again in the brace. And at that moment, I went home, my mom picked me up and said, let's go talk to a surgeon. So, but the literature has never been proven. Now, when we use it on linemen, we use it in football preventatively. It's actually for collateral ligaments, MCL and LCL, the sides. Because those braces have those big side struts and hinges, so it prevents that varus valgus motion from occurring. So it can prevent a lot of these catastrophic collateral injuries and collateral ligament injuries in linemen. That's been proven in NCAA and also NFL literature. But for an ACL, it hasn't. And so for that reason, if the brace doesn't work to prevent an ACL from subluxating, then there's no sense in bracing it post-op, because either it's going to work or it's not. And I think what's more important, and what we tend to do with all of our athletes now, post-operatively, when they're done with their 6 months or so of their dedicated physical therapy and they're back running, as we put them through a bridge and then ultimately this prevention program. That's what we suggest to them, is to go to this neuromuscular side and strengthen the leg up that way, because we think, just as we've shown here, that's going to be the best at preventing this down the road as opposed to a brace. So, well, I want to thank you all for coming. This is really incredible. You always came, and thank you to all the young athletes out here, and good luck on the field and on the pitch. And thank you, coaches.